All right, Elena, how's it going, friend?
It's going pretty good. Thank you so much. I'm super excited to present this case. I actually haven't seen the patient myself, but our dear Academy member Alec sent this case to me, and I think it's going to be really cool.
Fantastic. Alec and Elena combo. I have my coffee, I have Vale, we're ready to go. Go for it.
All right, so in total, we're going to have six aliquots, and the last one is going to reveal the diagnosis. So for the chief complaint, we have a 45-year-old male patient who you know nothing about at this point, and he's brought in by EMS after having had a tonic clonic seizure. And doing it in full neuro VMR fashion. I'll stop here for your reflections.
Vale, you ask and you shall receive. What are your thoughts?
Thank you, Elena. I can breathe finally. But for sure, if I was in this patient, maybe not so much because, a seizure is for sure and can be an emergency. And I think when it comes to what seems like a generalized seizure in a fairly young patient, I think triggers are the first thing that comes to mind. I mean, if this patient is actively seizing, I will, of course, would like to know, would like to stabilize them first. And then thinking about triggers like the past medical history of this patient, maybe low glucose, maybe a medication. Um, and then also thinking about facts like how long has this patient been seizing, if it's the first time, if they're on medication. I think those are the first time. Other triggers that come to mind are infections and trauma that can also be quite important things to ask. And so, yeah, that's kind of my initial thoughts. How about you, Sharmin?
I'm just so excited. I'm discussing with a neurologist, So this is going to be great for me. No, I 100% agree with you. I think whenever I hear like somebody's coming in with that kind of generalized seizure, um, a couple of questions that always comes to mind was that witnessed or either they have like history of like prior seizures that made everybody think this is a generalized tonic-clonic seizure. You always want to leave a room open for whether you're dealing with a mimicker of seizure. Like sometimes like syncope has like some people have like some movements that can mimic a seizure as well. However, chances are we're dealing with a generalized tonic-clonic. And I really love your approach, Vale. I think as an internist, for me, like if this is turns out to be like an underlying epilepsy, that is like something that I will rely on my neurology colleagues. However, my job as an internist is to figure out what could have caused the seizure to come up, and I really love Vale's approach. Of like what could be the triggers from like any intracranial processes. Again, 45 is year old is very young. However, if there is any foci of seizure, if there are masses, if there is a stroke or anything that can cause any metabolic derangements, any infectious etiology, as Vali mentioned. And I really like that you emphasize like trauma. The couple of things that, as Vale mentioned, even before starting this, if the question is like, is this patient continually seizing? Are they in a post-ictal state? So doing a really quick assessment, make sure that first and foremost is like, is the patient protecting their airway, getting a vital signs, and thinking like whether if they're still seizing to push at least starting with like Ativan, lorazepam, to make sure you can break the cycle. And then if there is you need to protect our airway. Then it comes to like getting the history, whether like this is new or old, it was a witness, and try to get some history from whoever the patient was with, family member, emergency contact, and oh, I was gonna say something and then I forgot. So I think it's gonna come back to me at some point, or it was just like not as important. So let's just pause there and then, Vali, anything else to add?
I just wanted to say that I love that you emphasize to rule out mimickers of seizures because I do remember like migraines even can imitate seizures, and syncope is another one that it's very important to differentiate. And I think I remember from Aaron, he taught us that seizures are usually active, like positive things like movements or versus stroke or syncope, which usually are like negative things like immobilization of a limb or total loss of consciousness without any active movements. And I think other like questions that we typically ask, like if there was any release of sphincters like disease patients pee themselves, or if there are any injuries or signs in their tongues, which I also remember Maria, another OG neuro member, shared a while back that, there's apparently some research that shows that if you bite from the lateral parts of your tongue, that it's more likely to be seizures versus the anterior part, which apparently happens more often in syncope. So another like little thing to look out for if you're seeing this patient.
Beautiful. That was absolutely brilliant. All right, Elena, back to you.
All right, I'm absolutely loving this discussion. So the patient is currently incarcerated, and he was brought in after an assault last night. He reported that 2 people attacked him with their fists and possibly another unknown object, after which he lost consciousness and reports having had a seizure. However, there were no witnesses. The most notable consequences of the physical attack were multiple facial hematomas, laceration to the lower lip, and hematoma of the left ear. Upon further questioning, the patient reports pain overlying the facial injuries and ribs, otherwise denies acute dizziness, lightheadedness, nausea, vomiting, abdominal pain, vision changes, chest pain, fever, chills, and shortness of breath. In the context of evacuation of the left ear hematoma, the patient had another seizure that was characterized as generalized, tonic, clonic, and voluntary movements. He was given IV benzos with rapid resolution of symptoms, and the patient was fully oriented to all the qualities right after the event. For the past medical history, the patient has hypothyroidism. He has a history of epilepsy status post-traumatic brain injury, and he usually describes his typical seizures as head bobbing with right arm shaking, which is also consistent with prior chart documentation. He has bipolar and anxiety disorder and a history of prior alcohol use disorder. He's currently in remission. He also has chronic hyponatremia, and his baseline usually is around the upper 120s, and it's just thought to be related to the anti-epileptic medication he's taking. So for the meds, he takes Keppra and Valproate at jail. The last dose was last night. He takes aripiprazole, trazodone, losartan, levothyroxine, atorvastatin, and metformin. For the social and family history, so the family history is pretty much unknown. He is, as mentioned, incarcerated. He reports no sick contacts. He's not currently sexually active. He denies recent substance use and alcohol consumption while in jail. But he, as I mentioned, has a history of AUD. And actually for the AUD, he had multiple prior visits, but really denies any recent alcohol or substance ingestions. And I'll stop here.
Wow, what a rich aliquot, and I'm really sad for this patient for this assault that has taken place. Vale, what are your thoughts on the rest of the information Elena gave us?
Yeah, thank you, Elena. This is a brilliant presentation. I think I'm really scared for this patient because I've seen patients that come after an assault and have herniated on me when they have been really well, and then all of a sudden they've coded. So I will be sure to be, in an appropriate place to take care of this patient if they seize again or something worse, because I feel like, well, this patient has the back history or the background of having epilepsy already after a trauma, which means that they probably have an epileptic foci, like a scar in the brain that is seizing, which seems very focal by what Elena described. However, if you have epilepsy already, you can also have like something that lowers your seizure threshold. And that can be irritants of the electro balance of the neurons. So something like blood, for example, can irritate the neurons and for sure can cause seizures. And that's something that will be very worrisome if this patient is having like a subdural hematoma or even an epidural. I'm not sure about the time course of an epidural because it happened last night. But I'll be for sure looking. I will need imaging for sure. I'm not sure if I'll rely as much on my examination of the pupils. Even if this patient has some sort of limitation of movement, that can also happen in some times of herniation. Because as I've said, I've had patients that are completely normal and out of the sudden they herniate. And then I think I'll also look out for, wait, it happened it happened just what happened to you the last time, Sharmin. I was about to say something and I totally forgot. So I'll pass the mic to you.
Oh, well, if it comes back to you, please unmute because I want to hear all the amazing Valley nuggets that you're sharing. And yeah, your reasoning is 100% sound. We're having, and I'm worried about this patient with you that, like head imaging as soon as possible, for sure, to make sure there's any intracranial process that is going on. And you're right, someone who's like younger can decompensate it quite fast because just they have a bit more reserve until they're okay until they're not okay. So that's a really good gestalt to carry with you to, especially in these patients, because to make sure you get the evaluation urgently as possible. And I think like absolutely, as you mentioned, like a history of epilepsy does make you more prone for new triggers to cause another seizure. However, I want to be mindful of that. Like, he sounds like the seizures that he gets from his epilepsy are tend to be more focal, and what is now seen as a more generalized tonic-clonic seizure that is like a kind of a different manifestation. And as you mentioned, like absolutely, like epilepsy can present in many different forms, but being open to the possibility that this might not just be from his epilepsy, that we're dealing with something else, as you mentioned, with his history of trauma. I think intracranial hemorrhage is a big one to think about, like dissections, any like damage to facial and then CNS system. I'm also struck that, he might have other reasons as well. He has like chronic hypernatremia, whether that has like in a setting of pain or assault, if he has like acute worsening of that can lead to seizure. In terms of like his medications, often is the one to scrutinize with for people who have underlying epilepsy. There are many medications that lower seizure threshold, and also if anything were to have happened for him not to have received his medications or not have been taking it, and just like being open about like asking about those questions. And I think like valproate acid is the one that you can easily get levels in most of the, at least like the US hospitals. So I think that's like a fair lab to also get. The one that I have to look at, like I think like when it comes to like psychiatric medications, a lot of them do lower seizure threshold. I'm actually not sure if aripiprazole can do it or not. It's not the one that is on my short list. However, that's the one that I kind of look up to make sure while the patient is here, I'm working them if there are any other changes we need to make going forward. And this patient is incarcerated, and as Elena mentioned, most likely don't have access to a lot of substances. But I'm always happy to be humbled. Again, like I think with any patient is all about building trust and being curious and uh, having alliances with the patient that they're open to you if by whatever reason he had gotten his hands on something. It was just like discussing with a patient in a way that is non-judgmental, that allows them to give you more information, because also you don't want to do $1 million workup if there is any substances or anything else on board. So and that might not happen in the first 5 minutes you meet the patient. That might happen the next day, and that's okay. I think one of the things that I like about inpatient medicine is your ability to build a relationship, because you get to see them day after day. So I think like for this patient, as you mentioned, like starting with a quick exam and like really urgently ordering that non-con head CT, the labs. And then I think once the non-con head CT result is back, we can either be more nervous or take a deep breath and think a little bit more thoroughly. Vale, anything else to add?
Nothing at all. That was amazing.
All right, Elena, back to you.
Yeah, I love this discussion for so many reasons. And in the next aliquot, you will get the exam, labs, and imaging. So the vitals are all within normal limits. The patient has a BMI of 33. The patient is awake and alert at the time of examination. You see the orbital hematomas with associated swelling, the lower lip laceration, and the left ear hematoma. He has no tongue bites, no encopresis or enuresis. He has no neck tenderness, lungs, cardiovascular and abdominal exam are pretty much normal. The skin is warm, dry, and well perfused, and extremities have no edema, no rashes. For the neurological exam, the patient is alert and oriented ×4. He's mentating appropriately, following commands, and answering questions appropriately. Cranial nerves are intact, and so is extraocular movements, strength, and sensation. For the labs, he has a sodium of 124, which is a little bit below his baseline. Potassium is 3.9, chloride is 88, CO2 is 36. I'm gonna paste these in the chat. BUN is 5, creatinine is 0.6, glucose is 128, calcium is 8.5. The LFTs are normal. TSH, FT4 were drawn because of the hypothyroidism. We're all within normal limits. CBC and COX were normal as well. For the workup of the hyponatremia, they got a serum osmolarity, which is 280. The urine osmolarity is 216, and urine sodium is 49. The interpretation of these labs is a little bit limited because the patient was given normal saline, and the sodium already started improving a little bit. He also got a CT head and chest X-ray, which were negative for any fractures or any further consequences of the assault apart from the hematoma of the face and ear. And that's the third aliquot.
All right, Elena, thank you so much for presenting this case. So full of learning. Vale, what are your thoughts about the exam and the labs?
Yes, thank you. Well, I think for this patient, I guess what was I expecting of the exam? Well, it seems that he's pretty bad in terms of the injuries that he has in his face. So I would think maybe look out for any signs of a skull fracture, like if he's having any drainage from his ears or nose, but it seems like he's not. And he seems pretty stable neurologically. Then when it comes to the exams, I mean, his sodium is a little lower. I feel like I have on my threshold for seizures for sodium is 120, or I'm not sure if 125 is when I should be worried. I mean, but you're the hyponatremia specialist, Sharmin. And then how do I I wasn't expecting on a neuro case to be quizzed about hyponatremia, but here we are. So how do I interpret this? Okay, so sodium is low. The serum osmolarity, it seems like it's on the normal range. So I usually, I would expect it to be lower, but well, he has received some saline, but we have the urine osmolarity, which seems like it is, it is high. And so, yeah, and the urine sodium is high as well. And I think, I mean, for this pattern, the first thing that comes to mind is SIDH. And in this patient that has a trauma on the head, it could be a possible cause of that. But then thinking about something that has worsened his SIDH, like this recent trauma, or maybe his hyperthyroidism, that could also be a cause. But I mean, it seems like it's pretty normal for the labs that Elena shared. And so, yeah, I think those are like SIDH will be probably the thing that I'm most worried, but I'm not sure if that can account for the active seizing. Like, is this sodium lower enough for we to attribute it to it? So that's where I would like your input, Sharmin, please.
Well, for someone who doesn't like sodium, you did a fantastic job, Vale. And I feel like sodium just sneaks up on you no matter where you are. Um, I feel like in terms of like the exam, I totally agree with you. And then another thing that like caught my attention earlier was that he had another seizure, and it sounds like his post-ictal period was actually quite short, which I'm not sure what to do with that other than just to point it out. And I think I'm like relatively, you're right, like assured by the exam. And I think like it was very, very thoughtful and smart to think about like if there's any drainage from the ear, to think about like if there's any CSF that is leaking that we need to worry about. I'm still waiting. And I think like the CT head being negative for any hematoma and any big intracranial processes, I think that is very reassuring. So now we have like a little bit more time to dig a little deeper. I think like trauma itself and stress itself can definitely be a trigger for his epilepsy and for him to have a seizure. However, that will be a diagnosis of exclusion, and we have to make sure there's nothing else contributing. The one thing that I wanted to mention, and then I forgot, and as soon as like Elena gave me the labs, I'm like, ooh, glucose, hypoglycemia. It's always the ones like when it comes to like rapid responses, I often forget about them. So for a while, I had trained myself as soon as a rapid call to think about glucose, because hyperglycemia can mimic a lot of things, and especially with seizures, a really good one of your first things to do is just to check a finger stick glucose. So I'm very thankful this glucose is normal. And in terms of like the sodium itself, the way I like to think about it, I think, is about the delta. So if the patient is always in the 120s, like for example, his baseline is like 126, technically a sodium of 124 shouldn't make you have a seizure because the delta is so tiny, so small. However, if the patient was like in the 130s, 140s, and now is like presenting acutely with 124, and in a setting of an underlying epilepsy, absolutely. However, I think the degree of that change and what affects epilepsy, I definitely is out of area of my expertise, but I would be cautious to attribute the sodium as a reason for the epilepsy. It could be contributing for his like seizure. It could be contributing. However, I think that at that point we're invoking like multifactorial process that would lead to lowering of his seizure threshold and for him to have that. In terms of your interpretation of like sodium was spot on. 280, oftentimes I think about 275 for the serum osm, 275, 280, like 0.5 of difference. So I think it's wise to think about both, whether it's we're dealing with a pseudo hyponatremia situation, and the pseudo hyponatremia, you think about elevated triglycerides, you think about anything big that is kind of contributing to the osm, such as like paraproteinemia, lipoproteins, and stuff like that. Or 175, 180, we're in the lab, as you mentioned, of like hypoosmolar hyponatremia, which with that serum osm and that sodium puts you in the category of like adrenal insufficiency, hypothyroidism. He doesn't have any hydrochlorothiazide, SIADH, and it kind of sounds like with his prior trauma, there was a concern for him having chronic SIADH, if I remember correctly. The interesting thing, one thing that Elena mentioned is that they gave him a little bit of fluids, and his sodium got better. I think the thing about tricky that is about sodium is that it's often multifactorial, and and you have to figure out at this moment in time what is the main driver of it. So it's like having been given fluids, that's okay. Just get your sodium labs and know that it's a window to that moment in time. So at that moment in time, this is what the sodium is telling you. It could be different 2 hours from later as patients eating, drinking. So I'm a big fan of like trending all of these labs and then kind of asking what sodium is trying to tell me. And I think perhaps what I worry about, like if he had some degree of like hypovolemia in addition to having chronic SIADH, if the sodium got better with a bit of fluid, which is a case that we often see in the hospital. People have chronic SIADH at times can be sodium still can improve with a bit of fluid. But this is someone that, you know, I would just be very judicious, and then I would probably not give any extra fluids too, and just trend the sodium and see what it does. Vale, where do you want to go from here? So we have like our initial labs, you know, nothing really major, thankfully, is popping up. What do you want to do next?
Yeah, this is a tricky one because I feel like this patient has had 2 seizures. And I love that you mentioned about the post-ictal state because it's something, of course, we look out for to think about neurocauses of loss of consciousness or if this is a true seizure, but it seems like it is, so we're beyond that. But yeah, I mean, in neurology, we have like 4 exams that we can ask for, and then the 5th one, which is to watch the patient and see how they evolve. I think for this patient, I love how you said that you would watch the trend of the sodium and let it speak to you as if the sodium was like an entity, which I feel like is very interesting, internist of you. So I will let the brain of the patient talk to me. No, I'm kidding.
I love that.
I just, I feel like at this point, I probably watch the patient. I'm assuming they have started maybe some antiepileptic medication, like a drip to stabilize his seizures and, you know, if he sees again, to be ready. I'll probably watch for recurrent seizures, then trend his sodium, probably repeat imaging if he seizes again, or if he develops any focality, like put him on a neuro monitoring, like doing the exam every 30 minutes or something. And then I'm not sure if any other metabolic causes, well, maybe something that we haven't done is doing urine tox to rule out any substances, anything like that, like the valproate to see if it is okay. Yeah, that's kind of where I'm at. Really, I don't know if I will do much more to this patient in real life.
Yeah, I agree with you. I think like definitely loading with an anti-epileptic makes perfect sense. Yeah, I would do kind of like my second pass, which is like thinking about like detox, getting a valproate acid, getting a history and documentation of whether like the patient was given medications, was taking medications, or not. Like the other things that are also like good to think about as you're doing like kind of post-seizure care is like complications of seizures that can happen. Like aspiration is a big one right now. The lungs are clear, but that could also be a source of infection that can also affect your sodium. Kind of like and you know, it sounds like, you know, we don't have any leukocytosis, we don't have any history of fever. So thankfully, like I don't think we need to go deep in an infectious workup, but just kind of make sure, you know, patient has like some underlying like, you know, HIV testing, Hep C, like the usual things that we think about for vulnerable patients. It's another thing to kind of think about as you're monitoring this patient closely. I don't, there's no focality for me to, you know, you mentioned the 4 exams of the neurologist, like MRI. I don't think at this point, I would also pull the trigger to get an MRI unless like something else pops up in the history or an exam that has a bit more focality to do that. And just kind of like watching his also facial exams. It sounds like, you know, he took a big hit to the eye with the orbital hematoma, just to make sure eye structure is intact. This is someone that might, the visual acuity is intact, might need ophthalmology to evaluate him as well. So kind of like looping in the post-seizure and kind of like post-trauma care, which I don't often do. So I'm just like thinking out loud with you all, would be kind of like my next steps. But I'm excited to see what you all did, Elena.
Yeah, because you both are way too smart, we're gonna have a little bit of a plot twist now. So on day 3 of admission, you get a rapid response call for hyperacute altered mental status for this patient with large volume emesis. So when you see the patient, he's very sleepy. He's not responding to questions. He groans to sternal rub. He moves all limbs spontaneously and seems to be protecting their airway. Capra is loaded, and when you look at the vital signs, you see a blood pressure of 70/40. On exam, pupils are equal, round, and reactive to light. Pulses are palpable throughout. Extremities are warm, and the rest of the exam is normal. You get a point of care ABG that shows a pH of 7.36, PCO2 of 43, PaO2 of 137, and the point of care glucose is 181. And I'll stop here.
Ugh, this is life, you know? You're on one train and then patient decides to be like, here I am. I have a different story to tell. So Vale, what are your thoughts on what happened?
Elena, and by any chance, were you like trending the sodium or in the ABG? You also got electrolytes?
The sodium got better and it was kind of like stable on baseline and also that day, yes.
Okay, yeah, because I was thinking because of I was reading the hyponatremia schema when you mentioned it, like with the hypotension, thinking about adrenal insufficiency, but it seems like no. So yeah, we have very unstable patient that has sudden altered status, and what seems like wait, sorry, I didn't get the okay. So yeah, I think for this patient, they did not refer any recurrent seizures. They just like suddenly got very sleepy, very somnolent. I think for patients that have the background of seizures, something that I always remind myself to think about because it is often missed, especially in the ICU, is to think about status epilepticus. But first, I would like to know if there's something that is triggering the altered mental status. So that will make us think about our mnemonic, our mismnemonic. And for that, I will go first with structural, given the past medical history of this patient and the background that they have. You know, if they have developed a hemorrhage that is now appearing and is rapidly progressive, which will be a little weird, but we have, you know, some subdural hematomas that can, you know, have this period of everything is okay, and then suddenly, you know, they get very bad. I'll repeat the exam for sure to know if there's any focality. And well, Elena mentioned that already, so never mind. And then I'll also like to rule out any other like well, metabolic derangements, which it doesn't seem like there is. The glucose is fine. The sodium is also fine. And then what else? Well, I really like infection is the other category of the mnemonic, but you know, an infection rapidly progressing like this, it will be weird unless this patient, you know, has had a slowly growing infection that suddenly appear with a seizure and, you know, coincidentally appear with a assault, which will be a very weird coincidence, but could happen. But I'm not sure if I'm ready to pull the trigger on the infection bucket yet. But what do you think, Sharmin?
Yeah, tricky. And you know, you all will be in this situation whether you're responding to a rapid response that is your patient or another patient's. And like I'm thinking as you go through your training, develop like how you approach rapid responses. I think a couple of things like if you show up to this patient and you're not the person who is like who knows this patient really well, always like start by like knowing their code status. So because like that would determine how urgency and how you want to approach and structure a rapid response. And then it's about like having them make sure they're connected to monitors and they're getting cycled with their vital signs as often. So that blood pressure of 70/40 is concerning. And while like what this was called for an altered mental status, that blood pressure, especially if this is a blood pressure, the patient whose like blood pressure has previously been like 120s, 130s, and now acutely to the 70s, like you really want to think about like, okay, hypotension, because what I need to do at this moment in time is to make sure that this patient that blood pressure gets better and I stabilize this patient. So I think thinking about like doing a quick exam, like getting a sense of their volume status, and as Elena did, getting a sense of like their mental status, protecting their airways. Sounds like, at least from the ABG, he's not hypercarbic. I'm sure they with that oxygenation they put him on some supplemental oxygen already. If the patient is like not, you're not worried about cardiogenic shock, and some clues to that is like the narrow pulse pressure, being cold on extremities, then you really want to like just push fluid to give yourself some time to be able to say, does the blood pressure respond? Sometimes like a leg raise test is a really good one to do, right? If the blood pressure is low, a Trendelenburg, raise the legs to get, again, some time, making sure you have good access. So a lot of the times in kind of a rapid responses, you have a lot of your colleagues, nursing, RT there. So asking people to get better accesses if you don't, and then draw labs. And what we call sometimes is like a rainbow labs, right? You want to draw everything because you can always like you draw your CBC, your CMP, lactate. We have a gas right now. And to just like to start getting information. And I really like, as you Valley, we're asking for an ISTAT. Sometimes the electrolytes are not very accurate in the point of care labs. However, they give you a sense if something is completely off. Um, and then once you find like something to grasp on, and once you do like kind of your first pass of like stabilizing the patient, making sure patient is on monitor, they're getting some fluids, you're recycling that, getting them onliner from, and this is who, if you don't know this patient, they will tell you like this is a patient who came in with like seizure, this type of trauma, and then you can think about like how these two are related. I agree, like this presentation doesn't strike me as someone who had seizure unless like, we're catching the post-ictal phase of his seizure, that he had a prior seizure and now he just like post-ictal, he had vomited, so he's at risk of an aspiration. So adding a chest x-ray, doing abdominal exam. I think he bought himself, as you mentioned, once he stabilized, another non-con head CT at least. And I would like definitely draw blood cultures. He's like hypotensive, so you're gonna think about like distributive, cardiogenic, obstructive, and your like hypotension approach. And again, like with someone who had like a trauma to a face, I don't know if you had like a trauma to chest that we have to worry about like kind of tamponade physiology or something like that. But at this point, I would kind of like overlap my altered mental status and hypotension and see if your blood pressure is like getting better, then will the mental status improve or not? And knowing that this is, you have a underlying that this could be kind of post-ictal, but you want to not anchor on the fact that this patient just has a seizure history, was coming with seizure, and now is altered. That is due to seizure alone, especially with that blood pressure. I am worried about that blood pressure. Val, any other thoughts?
No, thank you for walking me through that. That was amazing.
All right, Elena, what happened next? I'm on the edge of my seat.
Yeah, I think this is an outstanding discussion, and I'm learning so much. So as you said, the patient was given fluids, and peripheral levofed was started, upon which the patient improved in terms of their blood pressure. They also got imaging of the head, chest, and abdomen for the altered mental status and hypotension, and really showed no acute pathology. So it wasn't really clear why the patient was so hypotensive, but it was really like easy to manage them afterwards. Upon further review, you talk to the nurse, and they report that the patient had actually been in the bathroom for a pretty long period of time prior to this episode. And I've never heard of the term rainbow labs, but I think I'm gonna use it from now on. So you get those rainbow labs back at this point, and they reveal a serum osmolarity of 330 with a normal anion gap. And other labs remain unchanged, especially ammonia level, lactate, and the alcohol level is mildly elevated. And I'll stop here.
All right. Yeah, we call it rainbow labs because like the color of the tubes are all different colors. So the one that you want for your INR, CBC, CMP. So that's why like we call it rainbow labs. But I do love that term too. All right, Vale, what do you make of this additional history? Quite interesting.
Yeah, I'm stunned by the hypotension. I think it's interesting that Elena mentioned that the patient was in the bathroom, because I often, think about the bathroom like a place where you can have some effort, and that can lead to like orthostatic effort, or like like for example, like a vasovagal syncope after using the bathroom, which is a common trigger. But I'm not sure if it will be related to this degree of hypotension and a change in mental status. And then also the other thing that is interesting is the serum osmolarity, which is very, well, it's higher than before. And, with this serum osmolarity, I'm thinking about something in the blood that is, rising it. It doesn't seem to be the electrolytes, because they were normal. And so I will think maybe something else, like, did this patient ingest like alcohol? But the anion gap is normal, so I'm not sure about that. Or it's producing more lactate because they have had a generalized seizure, and they're maybe like in the posictal state, and they have a lot of lactate. I know that lactate can cause, I'm not sure about this actually, but I'm not sure actually about this. I was about to say that it could be, maybe something related to hypotension after a seizure, but I'm not sure. So yeah, I don't know. I think, someone else also mentioned in the chat before about the possibility of this being like because of alcohol, if they're in withdrawal, that can also lead to an elevated serum osmolarity. But with a normal anion gap, I really don't know. So yeah, I'll for sure rely on your expertise, Sharmin.
I don't know if I have much expertise, but I'm happy to think through it with you. Um, yeah, I think a couple of things that comes to mind. I really like, what do we do with this history of like this patient spending a lot of time in the bathroom? One thing is like patients constipated or having a lot of effort and have a syncopal episodes. However, doesn't quite present like this. The other question is like also to think about is like substance use. And the other question that goes along with that, that the patient has a visitor, do they have access to any substances? The other thing to also, sorry, I forgot to mention when we were talking about rapid response is that always like asking someone to look through their medication administration history. If the patient sometimes like have gotten opioids or something like that, then you want to think about like whether Narcan at that time would be helpful. So I think the question I think here is like, what is there anything the patient ingested that caused elevated like increased osmols? Yeah, with that anion gap metabolic acidosis, it is it's weird how I wondered like some of the alcohols, the toxic alcohols might not cause some of them might not cause like an ion gap. So that's something that I just have to look up. But I think like my suspicion for some substance use gotten up for cause of his like acute mental status. So I think if you talks, I think like getting some more labs would be helpful to investigate that. And as well, like if the patient's mental status is better, just like having a discussion with the patients about what could have happened in the most non-judgmental way possible. But that's something that I think at the especially now with like still making sure that you did your you're doing your infectious workup, you're looking for other etiologies. I think the imaging's being negative is reassuring, although it doesn't account for like episodic. And again, in the setting of an MSS, you want to really make sure if the patient didn't aspirate. Sometimes like aspiration pneumonitis can cause like some hypotension. However, without like hypoxemia, that would be odd. So I'm worried about a substance use. I think like the alcohol being a little elevated. I wonder if it's not. I don't know what else could cross react with that. So I think like that would be the train of thought that I would investigate with this patient. Any other thought, Valerie?
No, thank you for giving me that teaching point. I really didn't associate, like long periods of time in the bathroom with something, that could be suspicious. So I'll keep it in my back pocket. Thank you.
All right, Elena. Was there an awesome gap? Was the question.
Yeah, this is fantastic. Thank you both so much. So this is the last aliquot, and as you suggested, Charmaine, they talked to the patient and they got better, and the patient then admitted to drinking an entire 1.2 liter container of isopropyl alcohol, so the hand sanitizer in the bathroom. Which is also, they had like vomiting and all of that, and certainly like a high vasovagal tone. So that's like one thought that I had just for the, a severe hypotension that the patient had. And he recovered pretty well with just supportive care. So no dialysis needed or anything like that. The hand sanitizer products were removed. And for the hyponatremia, so as you both mentioned, just the like mild drop, it's really all about the delta. It was thought to be just due to like some nausea, vomiting that the patient had just the preceding days, and it improved really quickly with the intravenous fluid, and got back to baseline. For these seizures, so they were like actually ultimately felt to be more consistent with psychogenic non-epileptic seizures, just given prior chart review, which also revealed that he has had these before. There was like no post-ictal phase at all to this. He recovered super rapidly. There was no tongue biting, also like no EEG correlate, and he was always like distracted during those episodes. Yeah, so that's the case. I've learned a ton from you, and I'm super excited for your reflections. I have like one or two teaching points, but curious to learn what you think.
Wow, quite unfortunate. Thank you so much. This is such a valuable teaching case. Vale, what are your thoughts?
Yeah, thank you so much, Elena, for the amazing case, and thank you, Sharmin, for walking me through it. I think, this is one of those cases that are very sadly common, and I now feel more ready to tackle it after discussing this with you. Yeah, functional disorders in neurology for me are fascinating. I think, they're a little not misunderstood, because for sure this patient had a very real seizure. So I'm pretty sure that they got the care that they needed, hopefully, so that this doesn't happen again. And, thankfully it was not something worse in the sense that, something structural or a bleeding. So yeah, thank you for the case, and thank you for the discussion, Charmaine.
Uh, yeah, I know I totally agree with you, Vale. This is like very real for this patient, and we're not done trying to help this patient, right? Both from substance use disorder perspective and also from the neurological disorder that they have. Like a functional disorder is still a disorder. And the way I kind of think about functional disorder is that our type of disorders that we get to understand them, right? It's like we don't have a good grasp of them, as we have much to learn from them. And I think the most important thing is us to just never anchor on these on this and let it be a diagnosis of exclusion, just to make sure there's nothing else that is going on, because this patient has a history of epilepsy, so he is prone to having other disorders. And this perhaps, with the significant trauma that I experienced, I'm not sure if that was like kind of the trigger for the for like the kind of functional seizure disorder that he developed after this. But this is a patient who's gone through a lot. This is a patient who came in with an assault, who is incarcerated. And I think like making sure this patient stay connected with the resources that you have available would be really important. And having the mental health also supports that, sometimes we all need them. So I'm like incredibly grateful for the thoughtful care that he's gotten. And I have to read a little bit more about like I think it was isopropanol alcohol, like the ingestion. I think the fact that it was like so acute and it was like addressed quickly, that was really great. I really like we have calling our tox control centers whenever an ingestion happens, because it's not something that that I often see quickly, but they're really good about like giving us guidance about like what to do, what to look out for. The fact that I think he vomited was a good sign. I really like, Elena, your thought about like the vasovagal tone causing the hypotension, especially if it resolved afterwards. But I'm like really looking forward to hearing your cases, and thank you to Alec for sharing this very educational case with us.
Yeah, thank you both so much. That was an outstanding discussion, and I really, loved not only how you highlighted the complex medical, but also like non-medical part of this patient. It's a patient who probably is not able to get the best care, being incarcerated, and it's probably a very difficult situation. And yeah, I had like one or two reflections that I wanted to share. And I think for the first reflection, I need both of your experience because I'm not 100% sure. But I was really thinking about like when we see hyperacute altered mental status, I lack the clinical experience, but I think upon some literature review, it really boils down to just a couple of things. So when we see that, it's oftentimes acute vascular events, it's a seizure, or it's an intoxication, and I can't think of many more things. And I feel like as soon as this hyperacute altered mental status gets into the hospital setting, intoxications become even more likely, in my opinion. So that's kind of what I was thinking about. I'd be curious, Sharmin and Vale, what you're thinking about this. And for the awesome gap, I don't know. I think it's a really complicated topic, and nephrology is you have to be probably like a 10-year nephrologist to like get all of the uh, all of this. But I'm gonna try to highlight some of the things that I think I might have understood. So when we send a serum osmolarity, we're really asking the lab like what osms are in the serum, right? And when we measure the osms, then we ask like what osms should be there. And so here we can usually actually cheat because sodium accounts for 95% of the osms. And due to electrical neutrality, we can just say, okay, sodium times 2, and that's what we should have. And if there's a disconnect, then that's when we have an awesome gap, right? And then we know, as Vale mentioned, that we will have an additional solute that is not sodium, it's not glucose, and it's not urea that is present. And because it's actually a very rare instance to have an additional solute in the blood, calculating an awesome gap really only makes sense in the right clinical context. And I think with this patient, having been in the bathroom, acute altered mental status, and actually the patient had done this in a prior visit before, so the suspicion was pretty high. They got an awesome gap and got the serum osmolarity. And then the question really is, if we have that awesome gap, like what's the molecule, right? And I learned in med school that it's toxic alcohols and nothing else, but actually there's a myriad of things that can cause this. If we give patients antibiotics and all these solutions, they can cause an awesome gap. If you give them IVIG, mannitol, they all cause an awesome gap. So it doesn't always make sense to like get that serum osmolarity to like make that measurement. And I think another interesting point, and I think he mentioned this in the chat, is that the patient had a normal pH. And many of those toxic alcohols actually get converted into acids. And then you will have an acidosis. And there's actually just one exception, and that's isopropyl alcohol. And so it's like really the one circumstance where you can have also ketosis without acidosis. Because they produce acetone, and it's really the only ketone that is not acidic. So it's just an interesting thing, I think, to know about the anion gap. Like, don't ask me why it was normal. I would assume it would go up anytime soon. So yeah, in summary, I think the ABG perfectly represents the like features of isopropyl alcohol. You have a high osm gap, you have no acidosis, and eventually like ketosis, I would assume. Yeah, that's it from my side. That was so
Elena,
much
you're
fun.
so brilliant. Yeah, your analysis of the toxic alcohol, your reasoning, just absolute beauty to listen to. Yeah, I 100% agree with you. And I think like it can, Yeah, to me, it's also like, I don't know why there's no anion gap. Like, kind of story sounds like a toxic alcohol injection, but like listening to you, like, well, yeah, absolutely. And the other thing is like also the timing of the lab draws versus the ingestion. I agree with you. I think like I wonder if you had gotten the slabs like 3 hours, 4 hours later, what it would show, because also pathology is not instant. It takes time to develop. So we might have just not catched it at the moment that these slabs were drawn. And that was absolutely fantastic analysis. I loved listening to you. In regards to your question about the hyperacute mental status, I that sounds right to me. The one, I think, in clinical practice, the caveat is you don't always know when the patient started becoming altered. Unless like the patient, somebody's standing there and they're fine 1 minute and 2 minutes later they're altered. Oftentimes we don't know if the patient was altered for like 5 minutes, 2 hours, 5 hours. I think that is the tricky point, and that's why like a lot of times I think the hyperacute and acute altered mental status schemas merge in inpatient settings, because I don't always know when I show up if the patient was altered was like okay 2 minutes ago, or were they okay like 3 hours ago, if that makes sense. All right. Thank you all. This was thank you all to everybody who was like contributing with the chat. Thank you for scribing, and Gerardo, to you for the teaching points.
Oh, thank you so much to pass me the mic. And yeah, I think this was a very complex case. I was just mesmerized by all your reasoning, especially all the teaching points that Elena highlighted. But if I had to try to make a try to explain this case, well, this is a generalized tonic-clonic seizure. And one thing that Valeria mentioned that is very important to think about is to think about triggers, which could be low glucose medication that lowers seizure threshold, infection, trauma, stroke, metabolic derangements like low sodium. And we need to think about delta and pseudo hyponatremia. The internist perspective that I liked a lot, it was, is it epilepsy or is it, or what is the actual cause? And also the responsiveness to fluids. We need to evaluate trends. So in a postictal state, we should not forget the differential diagnosis, and we should evaluate the airways, vital signs, stabilize, and review the past history to determine the diagnosis. Vale shared with us four key exams, and I think they are MRI, CT, and BMP. I really don't remember, but I'm excited to learn from Vale from those four exams. And the fifth exam, which was kind of the most important, which was watch the patient. Um, Here I also talk about the biting in the tongue. So if it's anterior, it could be syncope. If it's seizure, it can be the lateral tongue, which is a clue for diagnosis. And we also reflected about the post-insult seizure, a post-insult seizure, which is the differential diagnosis with, we should do the differential diagnosis with generalized seizure. And well, and this post-insult seizures should be analyzed with imaging, and this imaging should try to evaluate if there's blood, and also we should look at the pupils because that can worry us about herniation. And hyperacute AMS, well, we have to remember about Miss Mnemonic, and and Elena showed us a very interesting statement that we should try to think about altered mental status as a vascular seizure and intoxication just for practical purposes, and we should not forget the U-tox because excess alcohol is possible. Do not forget to ask when the patient started seizing, because we will never know when a patient actually started seizing. And also, we learned about rainbow labs, which I liked a lot, and I like the tubes, and I like the tubes a lot. And I remember those rainbow labs were osmolarity, anion gap, ammonia, lactate, and alcohol, where or 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 more. I don't really I don't really captured all the rainbow labs, but I love them. And finally, we analyzed psychogenic non-convulsive seizures, and we And there is a very important teaching point here, which is that the patient is the priority despite functional, and we shouldn't anchor on functional diseases. Well, thank you so much for your time, and yeah, I love the case.
Charlotte, you're so awesome. Thank you so much for walking us through your to the teaching points. And yeah, the four, sorry, I guess we didn't really talk about the four exams, but correct me if I'm wrong, Vale's like imaging, LP, EEG, and EMG are like the four neurological toolbox
Okay.
that they often
I'm
use.
I, I'm actually typing it at this moment. Thank you so much
Yeah,
for
of
the heads
course.
up. Yeah.
Of course. Thank you all so much. This is always a highlight of my day. We'll see you guys next time. Thanks, everyone. Bye.